Hi, good day to all of you. I'm Dr. Amit Vora, and this is a web-based activity on ECG learning which the Indian Society of Electrocardiology has started, and we hope that this benefits all of you in able to learn and interpret ECGs more appropriately. The topic today which I'm going to cover is on ECG identification of ischemia and infarction. When we do this, it needs to be understood that there are certain basics which need to be remembered very well. And one is that ECG should always be interpreted in the context of the clinical history. In isolation, if you read the ECG, then you are often likely to make mistakes, and therefore always keep the clinical history in context. We often see that there is an ST depression and we think that this is ischemia. One needs to realize that a fluctuating ST segment change, ST segment depression which normalizes, definitely is suggestive of ischemia, but you have a ECG which shows ST segment depression all the time. Few weeks ago, few month old ECG also has shown the same pattern. Then this might be a strain pattern and not necessarily an acute ongoing ischemia. Let's look at this ECG example, and this grossly shows that there is a significant ST depression if you see in the anterior precordial leads from V3, V4, V5 and V6. So also in 1 AVL, lead 2 and lead AVF. One would not doubt this ST segment depression, that this represents ischemia, and the clinical story would corroborate very well. But in the contrast, let me show you another example of an ECG of a young man who's been complaining of atypical chest pain, and therefore this ECG was recorded. What does this ECG show? Similarly, that there is a ST segment depression with a giant T wave inversion in the precordial leads, especially V2, V3, V4, V5 and V6. It also shows T wave inversion in the inferior leads. Now, if you see the ECG of this gentleman few months ago, it showed a similar pattern. Once you have a similar ST change over a period of time, it should make you suspect that this should be this could be a hypertrophy and strain pattern rather than it being acute ischemia. And that is where this figure helps you to differentiate between whether this is ischemia or whether this is hypertrophy. As you see on the right hand side, if you have ischemia, there is a tendency for the ST segment to be raised, and then there is a symmetric T wave inversion. But in hypertrophy and strain pattern, it's a secondary ST changes. So often you'll get an ST segment depression and then a T wave inversion which is asymmetric in nature. Often there is a terminal positivity to this T wave, which means that this is hypertrophy and strain and not an active ongoing ischemia. T wave inversions can be pretty non-specific and not necessarily represent ischemia, and therefore we need to again look at this more closely. For example, in children, you can find a juvenile pattern where you see precordial leads showing T wave inversion. This is quite physiologic till the age of 14-15 years of age. Even after tachycardia termination in post-pacing, you see that there is a kind of a memory effect and the STT changes are there. These again don't represent ischemia. In bradycardia, again, you can have a situation where there is delayed conduction because of which there is an STT change, and that STT change may not necessarily represent ischemia. T wave inversions can have many non-specific reasons, and including body habitus, posture, digestion, abdominal problems, and so forth. So the commonest T wave STT change, which is so-called non-specific, the pattern recognition on an ECG would be that the ST depression is very slight. The T wave tends to be low, flat or slightly inverted, not the giant T wave inversion which I showed. That clearly represents a strain pattern, and ST elevation with T inversion represents the ischemia pattern. If you get a fluctuant T wave where during pain the patient has normalization of the T wave, But at rest, if you have T wave inversion, like shown in this ECG, this clearly means ischemia. In fact, this is a representation of a critical LAD disease and has been labeled as Diswan sign, and Professor Valens had described this earlier. So fluctuant T wave which looks normal during pain but inverted during rest is a sign of ischemia again. Let's now focus on myocardial infarction. In terms of diagnosing infarction, as we said, that you need to keep the clinical context in mind along with the ECG. So you will have ECG changes to be identified, but simultaneously you need to know about the symptoms of the patient and also the cardiac enzymes. All put together will help you diagnose whether there is a true infarction pattern or no. So we will focus mainly on the ECG changes of infarction, and if you look at this panel, it shows that the various kind of ST segment and T wave changes which you can get in acute infarction process. The first step is to have a tall T waves. You will have an ST elevation, then is a development of an abnormal Q wave. Eventually the ST segment elevation tends to settle down, and simultaneously the T wave starts getting inverted, and in a old infarct you tend to have an isoelectric ST segment with only a T wave inversion remaining. So abnormally tall T waves, what could be the reasons? Of course, hyperacute T wave will show tall T waves, but it can happen in other situations which we need to keep in mind. Often in patients with ischemia, they tend to be symmetrical. The J point in the very early phases may be depressed, but eventually there will be a J point elevation along with ST elevation. The QT appears to be prolonged, and these are the classic manner in which an abnormal T wave of a acute infarction looks like. Let's look at this ECG example of a gentleman who complains of acute chest pain. And what does this ECG show? There is a tall peaked symmetrical T wave in the anterior precordial leads V2, V3, V4, V5. But where is the J point? If you clearly look in V4, V5, you find that this J point is slightly depressed. So this is a very early phase of myocardial infarction where the tall peak T waves are happening, but the J point is still a little depressed. In a matter of few minutes, this is the ECG pattern where the J point itself gets elevated and the ST segment elevation is still further, and this is more often recognized as an hyperacute anterior wall infarction. But I would like you to go back to the previous ECG that this is the earliest sign of infarction, and if picked up at this point in time, you can probably start therapy much earlier and the salvage of myocardium could be still better. So ST elevation is the hallmark of an acute myocardial infarction process, and it is localizing. So the leads which show ST elevation will help you to identify what area of myocardium is undergoing infarction. The extent of ST elevation also correlates with the extent of ischemia. More the ST elevation, more is the myocardial ischemia. The ST elevation tends to resolve in 2 weeks' time in vast majority of patients with inferior wall infarction, but in anterior wall infarction that resolution may not be in many patients, and some of these patients may persist to have an ST elevation for a long time, which represents nothing but a akinetic or a dyskinetic segment, and probably even a development of a LV aneurysm. So in terms of labeling infarction, which wall is infarcted, how do we correlate it with the ECG? And what we say is that the V1 to V3 leads are specific for an anteroseptal myocardial infarction. V2 to V5 is an anterior wall infarction. V4 to V6 is an anterolateral infarction. 1 and AVL is lateral infarction. 2, 3 AVF of course is inferior infarction, and a tall R wave with an ST depression and a upright T wave in V1, V2 is what we see in a posterior wall infarction. And you will realize that often you will have a combination of these walls. So you can have an infero-posterior wall MI, you can have an extensive anterior wall MI, anterolateral MI. So you need to look at these leads and then be able to tell which is the area of infarction. What is not well known is the grades of ischemia. Sklorowski has very well defined the severity of ischemia, grade 1, 2 and 3, where grade 1 ischemia is just the presence of a tall peaked T wave which help you to diagnose a myocardial infarction process. Grade 2 is ST elevation, which also is seen in all the patients. What is important is to understand the grade 3 or the severest form of ischemia which some of these patients tend to have, which will appear on an ECG like a distortion of the terminal portion of the QRS, such that there will be either a disappearance of the S wave completely, or the J point elevation is so high that if you take the ratio of J point elevation to the R wave height, it is more than 0.5. And let me show you certain examples. So upper panel is panel A, and that shows an anterior wall infarction. Panel B also shows a anterior wall infarction. But if you see in the panel B, you have a J point elevation in the precordial leads, which is what, way more than 50% of the R wave height. You see that there is an S wave in the panel A in lead V2 and V3, and that S wave is completely disappeared and the J point is sky high. So panel B is the one which shows grade 3 or severe ischemia, as opposed to panel A, which is just showing you an anterior wall infarction process limited to grade 1 to grade 2 ischemia because of tall T waves and ST segment elevation, but the terminal portion of the QRS is not distorted. Similarly, if you have an inferior wall infarction, in an inferior wall infarction, you have ST elevation in 2, 3 and AVF seen in the upper panel, and in the lower panel also you have the inferior wall infarction. The difference between the two being again that the J point elevation. The J point elevation is more than 50% of the R wave height in the lower panel, which would mean severe ischemia. So though inferior wall MI isolated might have a relatively better prognosis, the severity of ischemia would also add to the prognostication in terms of how well these patients are likely to do and what could be the compromise in their LV function. So this is a example of severe grade 3 ischemia when you see in an inferior wall the ST segment is more than 50% of the R wave height in the inferior leads. And why is it important? When I show you the next part of the same patient, this is what you will realize. The severer the ischemia, the more chance that they can have a ventricular arrhythmic event, ventricular fibrillation and collapse and sudden death, which needs to be aggressively identified and treated. So if you knew that this is grade 3 ischemia, if you knew that this patient potentially likely to get into a VT-VF situation, you will aggressively treat his ischemia and hopefully prevent any fatal outcome in the acute phase. Now moving on to the Q waves in myocardial infarction process. A pathological Q wave to define a myocardial infarction has to be identified. So it has to be more than 40 millisecond in width. That is what tells you an abnormal Q wave. The depth of the Q wave also is important, such that it should be more than 25% of the R wave height for you to say that this is an abnormal pathological Q wave suggestive of an infarction. Of course, there are certain exceptions, and lead 3 is a classic exception wherein you may get a deeper Q wave, a very small or no R wave, but yet it is not necessarily means inferior wall infarction. Q wave, if it is confined to AVL alone and no other leads, again would mean that this is not necessarily and often in these leads we say that the Q wave needs to be more than 50% of the R wave in lead AVL for you to define that this is a pathological Q wave. Eventually in anterior wall infarction, after J point elevation, tall T wave, J point elevation, ST segment elevation and development of Q waves, you have an ST segment which tends to settle down, and eventually the T wave also starts inverting. So when you have this T wave inversion happening, it often becomes a close differential between a pericarditis versus an acute myocardial infarction process. And the way to differentiate between the two is that in acute pericarditis, the T waves don't get to inverted until and unless the ST segment is isoelectric. as opposed to an ischemic process. In an infarction setting, the T wave will start getting inverted even while the ST segment is elevated. So that change happens simultaneously, as opposed to in pericarditis, where the ST segment settles first and then the T wave inversion starts appearing. And this was an ECG of a young boy, which was missed earlier as saying that this is a case of pericarditis, because it's a young boy, atypical chest pain, and there is an ST elevation which seems to be present in almost all the leads, with an ST depression seen in AVR as well. But if you notice in the lateral leads V4, V5, V6, you are seeing an ST elevation with a T wave inversion. That would mean that this is very likely to be an infarction process and not pericarditis. If it were pericarditis, the ST segment would have been isoelectric and only then a T wave inversion would have come up. In terms of anterior wall infarction, it is also, there are more information that you can tease out in a patient with the ECG, from the ECG. And what we should try and find out is the extent of anterior wall infarction. So it is true that diagnosis of anterior wall infarction comes up from the anterior precordial leads, but when it comes to identifying the site of occlusion in the left anterior descending artery, which is what is responsible for the anterior wall infarction, you will have to take help of the limb leads. So you will try to look at where the ST segment shift is in the limb leads to be able to say where in the LAD artery the occlusion is resulting into an anterior wall infarction. So left anterior descending artery leads to anterior wall infarction. The major branches are septal and diagonal. So if you have a occlusion which is proximal to the first septal artery, then you will often get an ST elevation in lead AVR. If you have a proximal occlusion to the first major diagonal, then you will have an ST elevation in lead AVL. And in the mid segment, if there is an LAD occlusion, it often will show an ST elevation in inferior leads also. This is important because often in anterior wall infarction, if you see ST elevation in inferior leads also, you get a feeling that ST elevation is there in all the leads. But this ST elevation in the inferior leads in fact tell you that this must be a mid to distal LAD occlusion, as opposed to an anterior wall infarction wherein you have ST depression in the inferior leads. So ST depression in the inferior leads would mean that this occlusion in the LAD is much more proximal. The ischemic vector is proximal, going away from the inferior leads, and therefore you get an ST depression 2-3 AVF. So in an anterior wall infarction, ST depression in inferior leads is much more sinister than an ST elevation is. Again, this diagram shows the same thing, that if you have more than 2.5 millimeter ST elevation in lead V1, it means a proximal LAD occlusion, proximal to the septal also. You have an ST elevation in AVR. You can get a right bundle branch block with a proximal LAD occlusion because the right bundle branch gets the artery from the first septal, blood supply from the first septal, and you have a ST depression in V5 and in inferior leads with a proximal LAD occlusion. And this is an example of an ECG in a patient who had an anterior wall infarction. And what does this show? There is a QR pattern in lead V1, V2, meaning thereby there is an anterior wall infarction with RBBB, which immediately tells you that there is a proximal LAD occlusion, proximal to the first septal, which is what supplies the right bundle branch block. And if you look at the angiogram, clearly the first septal is seen and the occlusion in the LAD is proximal to the first septal. This leads to a large infarction. So identifying this helps you to prognosticate also. Let's move on to the inferior wall infarction. Inferior wall infarction obviously is diagnosed from ECG changes in the inferior leads 2, 3 and AVF. If you have an ST elevation, it would mean it's an inferior wall infarction. But the inferior wall infarction can occur either because of a right coronary artery occlusion or a left circumflex artery occlusion. So you need to identify which of these two arteries are occluded, and you can do that to a fair bit accuracy from the ECG itself. And one needs to understand the presence of an RV infarction. So right-sided precordial leads become very, very important. So rather than having a 12 lead, a 15 lead ECG where the right precordial leads are also taken, or the posterior leads also being taken, will help you to pick up RV and posterior wall infarctions. And that's where the significance of ST depression in the anterior leads in an inferior wall MI will come up, which will help you to decide whether this is a circumflex artery occlusion or no. And let's look at this diagram. So if you look at the heart and then overlap the Einthoven's triangle, you would realize that in an inferior wall infarction, the circumflex artery more or less falls into the lead 2, and therefore you will have a ST elevation in lead 2 more than in lead 3. As opposed to RCA, the vector seems to fall more towards lead 3, and therefore in an RCA infarction you will have an ST elevation much more prominent in lead 3 as opposed to lead 2. And of course in circumflex 1 and AVL also can show ST elevation. Importance of lead V4R in inferior wall infarction. It is very, very important, because if you have an RV infarction, you will be picking it up from the V4R ECG, and if you have a ST segment elevation of more than 1 millimeter in V4R, it would mean that it's a proximal RCA occlusion. Again, this would mean large myocardium at Jeopardy. But if you have no ST segment elevation and just a positive T wave coming up in V4R, V4R normally should have an inverted T wave. If a positive T wave is there, it would mean a distal RCA occlusion, because there is no ST elevation in V4R, no RV infarction, and not a proximal RCA occlusion. But if you have an ST depression in V4R with a T wave inversion, it in fact would favor occlusion of the circumflex artery. So V4R also helps you to differentiate between RCA and circumflex occlusion. So how do we diagnose RV infarction? We spoke about proximal and distal RCA occlusion based on V4R. It is important to realize that RV infarction is more often associated with cardiogenic shock, with AV block, and there is a higher incidence of ventricular tachyarrhythmia, and that is why it is important for us to identify the presence of RV infarction. In inferior wall MI, because of an RCA occlusion, you can also try to identify whether this RCA is a very large artery or no. A dominant RCA is the one which gives rise to the posterior descending artery also, and a superdominant, we call it when you have a posterior left ventricular branch also coming from that RCA. So how do we diagnose whether this RCA is large or whether this RCA is small? For that, we now, instead of looking at the inferior leads, we should look at the precordial leads. So if you have a inferior wall infarction located showing you ST elevation in inferior leads and the anterior precordial leads V4, V5, V6 completely normal, it's possible that this is a non-dominant right coronary artery. But along with ST elevation in the inferior leads, if you get an ST elevation also in V5 and V6, it would mean that there is probably a dominant RCA supplying the PD, and therefore the posterior area of the heart, the lateral area, and therefore V5, V6 also showing an ST elevation. But if you have an ST elevation which is much more marked, more than 2 millimeters in V5, V6, it is likely that this is a super dominant artery giving rise to not only the PD but also the PLV. Let's look at some of the examples, and this is a 62-year-old diabetic who is presented with acute chest discomfort. You can clearly see the irregular RR, and you need to follow this very closely, and you will realize that this is a kind of an AV Wenkeback happening, and in the latter half you can see a high-grade AV block also. The fact that there is an ST elevation 2-3 AVF would prove the point that this is an inferior wall infarction. Lead 3 showing more than lead 2, pointing towards RCA. Also the AV block pointing towards an RCA occlusion. And as I said, it's important to have the right-sided precordial leads. So if you see V3R, V4R, you are seeing an ST elevation. ST elevation is there and an upright T wave is there. So there is a proximal RCA occlusion and also an RV infarction happening, and this is what has a bad prognosis, which we need to look at it carefully. And the angiogram of this patient showing a proximal RC occlusion 100%, which required angioplasty. And once the angioplasty is done, you can also see that this is a dominant artery. And let's look at the ECG once more. And if you look at this very first ECG in V5, V6, we spoke of a ST segment elevation in inferior leads, in inferior wall infarction would mean that it's a dominant artery. And if you go back and see V5, V6 is showing ST elevation here, telling us that yes, this could be a dominant right coronary artery and is occluded proximally and has an RV infarction, has an AV block, worse prognosis, and this is what is corroborated on the angiogram as well. In inferior wall MI, diagnosis again by looking at the inferior lead ST elevation, but as we said, you should look at the opposite leads also, meaning the pericardial leads, to be able to tell you whether there is, and try to tease out more information. And what information can it give you? If you, with ST elevation in the inferior leads, you would expect as a reciprocal change ST depression in V1 to V3, so that can be seen. If along with that V1, V3 ST depression, if you have tall R wave in V1, V2, it would mean a posterior wall infarction. But if you have say ST depression which is kind of persisting in V4, V5, V6 also, that is a sinister sign, because these are not the reciprocal leads of an inferior wall MI, and that would mean that you are likely to have a triple vessel disease and probably a worse prognosis. So a proximal circumflex occlusion is basically identified by leads 1 and AVL showing an ST elevation, and in the inferior lead 2, 3 and AVF, lead 2 showing an ST elevation more than lead 3. And let's look at some of the examples. And this is the one which shows ST elevation in inferior leads 2, 3 AVF. 2, the ST elevation appears to be more than lead 3, and there is an ST depression in the anterior precordial leads V1 to V3. There is not much ST elevation in lead AVL, but this is one which is likely to be a circumflex artery purely on the basis of ST elevation in lead 2 being more than lead 3. And this is the angiogram which proves the point that this is circumflex artery occlusion. It's always good to be able from the ECG to correlate where the infarction process is, because this helps the to know how large area of myocardium is at jeopardy, and also for the interventionist how to be prepared with doing the angioplasty as well. How to diagnose left main occlusions? Left main occlusion will show a very funny pattern where most of the leads tend to show ST depression and very few leads, if at all, will show an ST elevation. The ST elevation will be seen most often in the basal lead, so to say. So lead AVR, lead V1 show an ST elevation, but rest all the leads can show an ST depression, and so often you will see more of ST depression than an ST elevation, like for example in this middle-aged lady where there is acute chest pain, and if you see, you can identify ST elevation slightly in AVR, in AVL, in V1 and V2, but rest all of the leads tend to show an ST depression. And this patient, when the angiogram was done, had an ostial left main disease. What are the ECG patterns of a non-ST elevation MI? So now this is a myocardial infarction process, but some of the times you will have ST segment which is not elevated. And what are the different patterns? One of them I did show you earlier, where during pain you have T wave which is normal looking, and at rest you have T wave inversion, this one sign, or Dr. Valence's description of a critical proximal LAD occlusion. So that's one pattern. Similarly, you can have in circumflex artery occlusion where you have V1 and V2 showing an R wave and an ST depression. So there's no ST elevation. So these are non-ST elevation MI, so to say, which can happen in patients. So essentially, it's a situation wherein you have infarction diagnosis based on the history, infarction diagnosis based on the cardiac enzyme elevation, but you don't necessarily have an ST elevation, which is the hallmark of otherwise an acute myocardial infarction process. And this is once again showing you this example of a gentleman who in the absence of pain shows T wave inversion, but when he's complaining of angina, the ECG is more normal looking, T waves are upright. This is classically of a proximal LAD stenosis. I will sum up now with the last example of anterior wall infarction and left bundle branch block, because this often is a confusing subject in itself, and Garbosa's criteria are the one which helps us to identify in the presence of LBBB is there a myocardial infarction process or no. So an LBBB patient can either have an acute MI or it could be that he has an old MI. How do we identify that? As far as the acute MI diagnosis is concerned, we have to remember 4 points. Number one is ST elevation of more than 1 millimeter in the leads which show concordant QRS, meaning thereby in lead 1 AVL where there is an R wave in left bundle branch block, you normally are expecting an ST depression and T wave inversion as a secondary STT change. But opposing to the secondary STT change, if in lead 1 AVL, V5, V6, if you have an ST elevation even by 1 millimeter, it would mean that this is an anterior wall infarction with an LBBB. This is in the concordant leads. What about discordant leads? Because in the anterior precordial leads, in an LBBB, you will see that V1, V2, V3 already shows you an ST elevation. The left bundle branch block itself shows you an ST elevation. Here, if the ST elevation is much more marked, more than 5 millimeters, it would mean that there is a anterior wall infarction in the presence of a left bundle branch block. And if you have a ST depression coming up in the precordial leads where you are expecting a secondary STT change, it would again mean that this is an anterior wall infarction. So the secondary STT change being absent and showing a primary STT change would mean that there is an anterior wall infarction in the presence of a bundle branch block. And the same in terms of positive T waves in V5, V6 would again mean that there is a infarction process going on, because normally you would expect with bundle branch block alone T inversion in V5, V6. Presence of an old MI in a patient with LBBB is identified by the Q wave. If a Q wave, no matter how small, if you get in 1 AVL V5, V6 in a patient with left bundle branch block, that would mean that this is an old infarction, because normally with LBBB you will not get any Q waves in 1 AVL V5, V6. And of course, even if you see an ectopic in an LBBB patient, the ectopic in fact unmasks the underlying pathological Q wave, and you get a QR pattern which would again tell you that there is an infarction happening. So this ECG example of a left bundle branch block patient, and if you see, there are 3 things which you need to notice. In lead 1 and V5 where the R wave is tall, you are seeing a concordant ST segment elevation of a millimeter or more, which would mean acute infarction process happening. You also see that in the precordial leads, the ST elevation is more than 5 millimeters in the discordant segments, and this all means that there is an infarction. There is a small Q wave also in AVL, again telling you of a anterior wall infarction in the presence of an LBBB. Summing up, you need to realize that there are certain pitfalls in ECG diagnosis of myocardial infarction, and the first and foremost is that at a very early presentation, normal ECG can be found in almost 50% of the patients, and that is where lies the ability to take a good history, have a high index of suspicion and get his cardiac enzymes, or ask for a follow-up ECG, and that will tell you the diagnosis. In 10% of patients, we see that you wrongly tend to diagnose myocardial infarction process in absence of a ischemia. You're still getting Q wave and ST segment changes which make you suspect that there's an infarction process, and wrongly thrombolysis have been given to these patients, and there's a long list to this subset, but briefly I showed you example of left ventricular hypertrophy and strain pattern, early repolarization, bundle branch blocks, acute pericarditis, Wolff-Parkinson-White syndrome, hyperkalemia. All these things can give you a suspicion, but you need to rule this out that these are not infarction process and these patients don't require thrombolysis. And of course, we talked about having a more than 12 lead, a 15 lead, 20 lead ECG, where not only the anterior precordial leads but right precordial leads and posterior leads are taken to be able to diagnose the area of infarction. So let me conclude, friends, by saying that ECG is most useful tool for initial evaluation, risk stratification, triage and guidance of therapy in patients who have chest pain. Should always be correlated with the clinical setting and the enzyme levels. ST depression and T-wave changes can occur due to many other causes other than ischemia, should keep that in mind. And localization of culprit vessels can be reasonably performed by early ECG, especially in a single vessel disease with a good sensitivity and specificity. I thank you very much and hope that this whole exercise has been worth it, and you have the slide set now with you to go over them in greater details. Thank you very much.